Feels like I've opened my eyes again, and the colors are golden and bright again. There's a song in my heart, I feel like I belong. It's a better place since you came along. It's a better place since you came along.
Hello everyone, and welcome to our seminar. We have a very interesting program lined up for you today, and I'm sure that you're going to enjoy it. We will be hearing a talk by one of our orthopedic surgeons on advances in this specialty for bloodless patients. In addition, during our last seminar, many of you left comments for us at the end of the program requesting information on certain topics. Well, we heard you, and we are pleased to present to you today a few interviews with some of our physicians who are going to address your questions, and they're going to discuss the topics of wound care, sleep apnea, hospital medicine, and depression. So thank you for these wonderful suggestions. Please keep them coming. You'll have another opportunity to request additional topics at the end of this seminar today. Well, before we get started, we'd like to hear from our manager, Ramon Correa, who would like to welcome you to today's program. Ramon, please.
Hello, and welcome to our program. We're so happy you could join us today. But before we get started, we want to remind those in the area that if you need urgent medical care, Englewood Health has opened various urgent care centers throughout northern New Jersey, where you can get quick, efficient care with Englewood Health physicians without having to come to the hospital. On this slide, you can see the locations of our urgent care centers. The facility in Jersey City is directly across from the Jersey City Assembly Hall of Jehovah's Witnesses at Journal Square. At this facility, we will not only include urgent care, but we will continually be offering increased services. At full capacity in the near future, patients will be able to visit our physicians for all medical specialties at this facility. We hope that you enjoyed today's program.
Thank you so much, Ramon. Well, we are now going to introduce onto the program Dr. Jay Reidler. Dr. Reidler is an adult and pediatric orthopedic spine surgeon with Metropolitan Neurosurgery Associates and Englewood Health. Dr. Reidler's main clinical interests include minimally invasive spine surgery, complex adult and pediatric spinal surgery, scoliosis and kyphosis, common neck and back conditions such as disc herniation, spinal stenosis and myelopathy, artificial disc replacement, congenital spinal malformations, spinal tumors, and revision spine surgery. He is also interested in improving safety and outcomes in spine surgery using advanced intraoperative navigation and robotic technologies. Dr. Reidler completed his undergraduate studies at Harvard University, where he graduated summa cum laude with a degree in neurobiology. He received his MD from Harvard Medical School and his MPH from Harvard School of Public Health, with a concentration in healthcare management and policy. He did an orthopedic surgery residency at Johns Hopkins Hospital in Baltimore, where he was chief resident of orthopedic education, followed by an adult and pediatric comprehensive spine surgery fellowship at New York Presbyterian, Columbia University Irving Medical Center in New York. He obtained further specialized training at the Shriners Hospital for Children in Philadelphia, where he completed a dedicated complex pediatric spine surgery fellowship, and at the University of Pennsylvania, where he trained in innovative approaches for treating complex neck and back conditions. Dr. Reidler, we look forward to hearing from you today.
Hi, my name is Jay Reidler. I'm an adult and pediatric spine surgeon here at Englewood Health. Thank you very much for joining us. The title of my talk is Bloodless Spine Surgery at Englewood Health, Recent Advances in Our Techniques and Technologies. So I grew up here in Bergen County, actually just a couple miles away in Englewood, New Jersey, and my family's used Englewood Hospital over the course of our life and had such a great experience. It's amazing to finally be back here and now helping my community, as well as people from all across the world. So I joined a group named Metropolitan Neurosurgery. You may be familiar with many of the neurosurgeons who have been very active in the bloodless medicine program here over the past 30, 40 years. So after growing up here in Bergen County, I had an opportunity to work with some outstanding leaders in both orthopedic as well as neurosurgery spine over the course of my training. Here are some of the outstanding leaders who have taught me in both complex spine of the back as well as the cervical spine, and had an opportunity to train in both common and complex disorders in adult and pediatric spine surgery. So my clinical interests span both adult and pediatric spinal disorders. I'll treat any patient from babies all the way through seniority. And I treat the full spectrum of conditions, from common disc herniations and sciatica to complex disorders of the neck and back, such as scoliosis and kyphosis. I treat spinal deformity, trauma, infections, and spine cancer. And over the course of my training, I had an opportunity to train in both minimally invasive as well as traditional open techniques. And in my practice, I try to develop very personalized and hybrid approaches to treating the particular problems that a patient comes to me with. So in general, I will try to keep things as minimal as possible and use minimally invasive techniques, but I'm able to use those to treat very complex spinal disorders. And you'll see a little bit of that here. So now, turning attention to the bloodless spine program here at Englewood Health. Spine surgery has traditionally involved significant risk of blood loss and anemia. On the right is a picture from one of my fellowship programs where we treated a patient with a very complex scoliosis. In this surgery, we had to do a large spinal fusion extending across the entire thoracic and lumbar spine, and it did involve a significant amount of blood loss. So major blood loss has traditionally been associated with scoliosis surgery and kyphosis surgery, which is rounded back, as well as revision surgery, where we're correcting failed prior surgery, and tumor surgery, cancer surgery. Here at Englewood Health, we have the Institute for Patient Blood Management and Bloodless Medicine and Surgery. And the team has a long history of treating complex spine problems in patients for whom blood transfusion is not an option. We have combined orthopedic and neurosurgical spine expertise, and we use specialized techniques for blood management, both before surgery, during surgery, and after surgery. So I'll talk a little bit about this. So starting with preoperative blood management, we have patients meet with specialists from the Institute for Blood Management, and we have a very specific algorithm for detecting and managing any pre-op anemia. When necessary, we'll give iron supplementation and EPO in order to increase the amount of baseline blood in the patient. And we'll always make sure that they meet a specific threshold before beginning any surgery. With respect to intraoperative blood conservation, we have several techniques we use to minimize the amount of blood that is lost. For example, we pay special attention to the patient of the position. If there's any pressure on the abdomen, for example, that may increase blood loss. And so we make sure to position the patients in such ways to prevent as little blood loss as possible. We'll use techniques such as acute normovolemic hemodilution, which essentially thins out the blood so that when blood is lost, less blood is lost than usual. We'll make sure to use hypotensive anesthesia, which is reducing the blood pressure, again, to minimize the amount of blood that is lost in surgery. So application of specific medicines that help limit the amount of blood loss during surgery. And we have lots of different specialized electrical devices, such as the Aquamantis, which help control any bleeding once they start. Most importantly, we use cell salvage. So any blood that is lost during the surgery is recycled back to the patient. And finally, we have many specialized surgical techniques that I'll get to in a little bit. After surgery, we don't stop thinking about this. We're continuously thinking about how much patient blood loss there is and trying to reduce that as much as possible. So for example, we reduce the amount of blood tests, thinking about every single test, making sure that any blood that comes out of the patient is absolutely necessary. We pay very close attention to the amount of blood that may be coming out into the spine surgical drain. And we also have options such as postoperative cell salvage, where we can take the blood from the drain and return it to the patient when necessary. Importantly, we also use staging very frequently. So essentially, if a patient is unable to get through the entire surgery all at once based on the amount of blood that is lost, then we are comfortable staging that surgery and spreading it out over the course of 2 or 3 days if necessary. So looking at the patients here at Englewood Hospital who have opted not to have any transfusions, we've reviewed our cases over time, and we found that many patients with complex spinal disorders have been successfully treated at Englewood Health. And in the series that we've analyzed, no blood transfusions have been given. In approximately 20% of the cases, we've been able to perform such complex spinal surgeries by staging them over the course of 2 separate days. And we found that with judicious use of blood conservation techniques, complex spine surgery can be performed safely in patients for whom blood transfusion is not an option. So what are these techniques I'm referring to? Well, so I'll get into a few examples of spine surgeries that we perform and the techniques that we use to try to minimize blood loss. So one of the most common disorders in spine surgery is lumbar disc herniation. Over here on the slide, you'll see a picture of a herniated disc. You could see a piece pushing out into the spinal nerve roots. And here's another diagram. So we have a technique called tubular microdissectomy, where we dilate down to the area of the spine that we want to operate on. And in doing so, we're able to spare a lot of the muscles that would attach there, because essentially we just stretch them open with a small tube. And then we use a microscope to peer down, and it's almost like operating through a little bottle. We're able to keep pressure on all the muscles around and prevent any sort of blood loss from those areas, take out the disc, and then pull the tube out. And oftentimes you will have surgery without even less than 10 cc's of blood loss. And so that's one of the techniques we can use. And we'll use that both in a small type of surgery, but sometimes if we're combining it with one of the larger spinal deformity type surgeries, it's an option as well to try to minimize some of the blood loss. Here's an example of another common spinal disorder, spinal stenosis. So in spinal stenosis, oftentimes the goal is to release the amount of pressure on the nerve roots. And oftentimes there'll be something associated with the spinal stenosis called a spondylolisthesis, which is a slippage of the spine. Many surgeons will opt to perform a spinal fusion when there's a slippage of the spine, because that helps to stabilize things going forward. But that surgery, the fusion surgery, will oftentimes require more blood loss than if you had just done the decompression alone. So here at Englewood Health, one of the options that we offer to patients is what we call interlaminar stabilization. It's a non-fusion surgery that allows us to stabilize the spine using a device. In this example, it's what we call a Coflex device. It allows us to stabilize the spine after doing the decompression, but without doing the fusion. And this is one other technique that we can use in order to sort of minimize the amount of blood loss and the morbidity of the surgery in general. Here at Englewood Health, we also perform lateral lumbar interbody fusion, also known as an XLIF. Lateral lumbar interbody fusion is a minimally invasive technique for achieving spinal fusion when spinal fusion is the right answer for the patient. As I had mentioned, the traditional open spine fusion does involve a substantial amount of blood loss. Lateral lumbar interbody fusion allows us, again, to operate through a small corridor in a minimally invasive plane that involves very little spine disruption, as well as very little blood loss. And so here's several diagrams showing an example of that. This is a surgery that goes in from the side, and it goes behind the stomach cavity, but in front of the spinal muscles. And so we're able to tunnel down through a small corridor directly to the spine and insert a fusion cage. And by doing this, we often will be able to get the surgery done with just a few cc's of blood loss. And so to provide an example of that, here's a patient that had come to me. She's a 76-year-old woman, and she had a prior L4, L5 open traditional fusion. And here you could see the screws that were in place. And the problem is that she had breakdown of the spine in the area above. And so she had been referred to me from another spine surgeon who was recommending that I go and do a very large open surgery that would involve a substantial amount of blood loss. And I talked to her about this less minimally invasive option, the lateral lumbar interbody fusion. And so in this example, you could see now what we did is we used the retractor system to create a small tunnel down, and we're able to place this fusion cage in from the side. We're able to put in a plate above to stabilize everything. and the patient did fantastic. It was a small 2-inch incision. She lost less than 20 cc's of blood, and she was itching to leave the day after surgery. And she did leave the day after surgery. And she felt much, much better and avoided a very complex, traditional open, large posterior surgery where there would have been a substantially greater amount of blood loss. Turning our attention to even more complex types of surgery, scoliosis. So I'm very passionate about treating both children and adults with scoliosis and using, as I mentioned, the hybrid techniques to use minimally invasive techniques to treat very complex problems. So scoliosis is a curvature of the spine in the front plane. You could see an example over here. The most minimally invasive way to treat scoliosis, which I'm passionate about, is bracing. It's been proven that bracing can be very effective in preventing the need for any surgery, and I'm happy to see patients at any stage in time and guide them through the bracing process and hopefully get them through the condition without ever needing any surgery. When surgery is needed, I try to employ techniques that minimize the amount of surgery that needs to be done and the amount of blood loss that's involved in that process. So over here is an example. This is a 16-year-old girl who underwent a surgery for spinal scoliosis. And as you see, the curve involves both the upper part of the spine, the thoracic spine, as well as the lumbar spine. I use several techniques that allow me to not only affect the thoracic spine when operating on that part, but we can actually control the curve in the lumbar spine through a surgery that only affects the upper part of the spine. So this girl was able to, we were able to spare her lumbar spine where the most motion comes from through a surgery that just impacts the thoracic spine. And here's another example. This is a girl with a very wide scoliosis. She's about 15 years old. And again, I try to, in her case, the question is how far do we have to go down in the curve? And in general, I will always try to minimize the number of levels that are involved in the surgery as a way to try to prevent the general amount of blood that's lost during the surgery, as well as preserve the most amount of flexibility for the child afterwards. Now, one innovative technique that's been recently introduced to the spine community is called vertebral body tethering. And this is a solution for adolescent idiopathic scoliosis that involves no fusion at all. And it recently received FDA approval. So this surgery, rather than fusing the spine, we actually mold the spine as the child continues to grow. It uses a concept that has been used in orthopedics for many years. For example, a child with knock knees, you can put a plate on one side of the knee, and as the child grows, the knee will actually straighten. And so it's a similar idea here in vertebral body tethering. What we do is we go through the side of the spine and place screws as well as a rope that puts tension on one side of the spinal curve. And then as the child grows, the curve will straighten. And so this is a very innovative and exciting technique that allows for treatment of scoliosis without any fusion and with very minimal blood loss. Turning our attention to early onset idiopathic scoliosis, this is one of the most severe forms of scoliosis because children who get scoliosis at a very young age, oftentimes their curve progresses very severely and can cause issues with the heart and the lungs. And so traditionally, this has been treated with what we call growing rods. Over the course of the child's life, approximately every 6 months, the child will require another surgery in order to lengthen the rods as the child grows. Here we have an option that we call magnetic growing rods. And essentially, what happens is we place the rods in at a certain point in life, and then the child, rather than returning to surgery every 6 months, comes back to the office every 3 months or so, and we use a magnet to actually distract the rod. So as the child grows, the rod that's implanted inside will grow as well. Finally, one of the most exciting technologies that we have here at Englewood Health is called navigation, and this has been used widely to try to reduce the amount of blood loss as well as reduce the amount of morbidity and postoperative pain and length of stay for patients. So navigation is a more precise and efficient way of placing pedicle screws that uses intraoperative 3D navigation. Traditionally in spine surgery, screws have been placed by exposing the spine as much as possible for the surgeon to be able to visualize everything and place the screws where they think is appropriate. Navigation allows us to use very small incisions to allow the surgeon to place the screws without really having to see the whole spine exposed. And you could imagine how this will limit the amount of blood that will be lost during surgery and the amount of pain the patient will experience afterwards. And so the way it works is we have the patient in the operating room and we take an intraoperative 3D image. It almost looks like a CT scan. And then we have a computer device that will see our tools and tell us exactly where they're pointing, such that when we are placing the screws, it shows us exactly where they're going to be going. And this has been shown to be more efficient and safe and reduce surgical morbidity associated with spine surgery. And here's a few examples. You could see how just through operating through tiny incisions, we're able to place the screws accurately. And so here's an example. This is a 43-year-old gentleman who came to me with a prior failed decompression. So he had a lumbar spine surgery posteriorly through a traditional open means, but he ended up having progression of his disease, and he required a spinal fusion. And so we used a combination of two minimally invasive techniques to treat him. We use what we call an ALIF, an anterior lumbar interbody fusion, where we use a very small incision in the front of the abdomen and tunnel down to the spine and place a cage there. Usually very little blood loss is involved in that. And then after putting in the cage, we turned him around and we used navigation to place the screws. And so that involved very small incisions without any exposure of the spine, and using the computer we're able to precisely place these screws. And so this patient was able to achieve spinal fusion of L5-S1 with a few small incisions in the back and one small incision in the front, and he was able to leave the hospital with very little blood loss and a very short length of stay. So thank you again for joining us for this talk. I'm very excited to be here at Englewood Health and help treat patients for whom blood transfusion is not an option. If you have any interest in seeing me, please reach out to the Institute for Blood Management, and I'm happy to get you in and see you as soon as possible. Thank you very much.
Thank you so much, Dr. Reidler. That was very interesting, and we appreciate your being here with us today. Well, next up we have something a little different and something special. We are going to hear an interview with Dr. Shrikant Kondapanini with our bloodless coordinator, Leilani Rangel. Dr. Kondapanini is Chief of Pulmonary Medicine at Englewood Hospital. He is board certified in internal medicine, pulmonary disease, and sleep medicine. In his many years at Englewood Health, Dr. Kondapanini has published numerous articles on respiratory and critical care conditions and disorders. Dr. Kondapanini has particular interest in pulmonary hypertension, sleep disorders, sleep apnea, respiratory failure, and chronic obstructive pulmonary disease, or COPD. Dr. Kondapanini received his medical degree from Wayne State University School of Medicine in Detroit, Michigan, and did his internal medicine residency and pulmonary medicine fellowship at Temple University Hospital in Philadelphia, Pennsylvania. He has been an honored physician with the Bloodless Institute at Englewood Health for many years. Welcome, Leilani and Dr. Kondapanini.
Thank you so much for joining us today, Dr. Kondapanini. We look forward to you teaching us a little bit more about sleep apnea. What exactly is it?
It's my pleasure to be here. Thanks for having me. So, sleep apnea is basically a breathing disturbance at night when you're asleep. So what happens is it's a physical problem. It's not a medical problem like diabetes or hypertension, which is treated with medications. It's a physical problem, which means is when you sleep, all your muscles relax, right? Mm-hmm. And then even your muscles in your throat area, in your neck area relax. And what happens is these muscles can relax too much and collapse and obstruct your airway. So what happens then is you may not completely stop breathing. People notice when you completely stop breathing. But it can also be partial decrease in breathing. And when that happens, you get less airflow to your lungs. Less airflow means your oxygen levels can decline. When that happens, your brain senses it. Your brain wakes up a little bit to stimulate your muscles again, your neck, to breathe properly. So if this happens frequently throughout the night, you don't go into deep stages of sleep. Mm-hmm. Like I said, by not going to deep stages of sleep, you can sleep for 8 hours and still wake up tired or unrefreshed and feel tired throughout the day. And then also, sleep apnea can cause medical problems. I'm sure you probably heard sleep apnea can lead to medical problems, worsening blood pressure, worsening diabetes, raise your risk for a stroke as well.
Wow.
Yeah.
Wow. Wow.
And the reason for this is, well, kind of simple, really. Like, imagine someone chokes you right now. What happens to your blood pressure?
Skyrockets.
It goes up, right? What happens to your heart rate? Goes up. Okay. So that your hormones, your adrenaline level goes up, right? Well, at nighttime, what's supposed to happen is your blood pressure is supposed to go down.
Mm.
You're not moving. Your heart's not pumping. So for 1/3 of your life, you're seeing a lower blood pressure, which is healthy for your body. But instead, if the airway is collapsing and you're being stressed out, your adrenaline level goes up. Well, at nighttime, your blood pressure, instead of going down, can stay the same, or in some people, go up. And that can lead to more heart problems or lead to a stroke. And by adrenaline level going up, it can raise your blood sugar. Because remember, it's a stress hormone. When you get stressed, your blood sugar goes up. So that's how it can make your diabetes worse also.
So how does a patient know that they have sleep apnea? Do they have any symptoms?
So basically, if you sleep poorly, right? I mean, many people sleep poorly for a variety of reasons, okay? Actually, the most common reason for poor sleep is you work too hard. Okay, not spending enough time in bed, right? But other than that, some of the other symptoms are, do you snore at night? Okay, do you sleep for 6 to 8 hours in bed and still feel tired when you wake up? Okay, has anyone ever said you stop breathing at night? Do you wake up throughout the night? Okay, do you wake up 2 or 3 times to urinate? In other words, you're waking up 2 or 3 times to urinate in 8 hours, but then during the daytime you don't urinate 2 or 3 times. So that can actually be due to sleep apnea. Do you wake up in the morning with headaches? Okay, so do you feel tired or sleepy during the daytime even though you got 8 hours of sleep or spending 8 hours in bed?
Mm-hmm.
So these are very common symptoms many people have.
Mm-hmm. Are there any misconceptions about sleep apnea that you see among your patients?
Some of the misconceptions are some people think it's only a disease of overweight people. But actually, anyone can have sleep apnea. It's more prevalent in overweight people because weight is a main issue, risk factor for sleep apnea. But you can see it in some thin people as well.
But can you describe now how a patient is diagnosed?
Okay, so it's a very simple test, probably the simplest test you'll ever do. You go and sleep somewhere. Okay. First, you see a doctor, and they can order a sleep study. And sleep study could be done one of 2 places. Either it could be done in a sleep center where you go overnight and stay overnight from 9 p.m. till 6 or 7 a.m. And they hook you up with many monitors to monitor your breathing, what type of stage of sleep you're in. Are you having REM sleep? Are you having stage 1 sleep, 2 sleep, or 3 sleep? Or you can do a study in your own home. It's not as comprehensive, but for most people, you don't need the comprehensive study in the hospital. You can do it in your own home when you just look for sleep apnea and no other sleep-related issue.
Okay. So once a patient is diagnosed with sleep apnea, how are they treated?
Now, sleep apnea is a physical problem, right? So it's a physical treatment. So the whole idea is to keep the airway open. And so there's no medications for this. The most common treatment is something called CPAP. You ever heard of it?
Yeah, I have. My brother had one.
Yeah, exactly. It's CPAP, stands for Continuous Positive Airway Pressure.
Mm-hmm.
So you've probably seen people in movies wearing a mask at night. And what that mask does is hooked up to a little machine that gives air pressure. And that air pressure keeps your airway open. So sleep happens right here. This is where your airway closes up. This is where the money shot is, right? And if this is your airway, everything closes down partially like this or all the way. CPAP, it's a mask hooked up to a little machine that gives air pressure. And then air pressure keeps everything open. That's all it does. So it doesn't matter what type of mask you use. You can use any mask you want as long as you're comfortable with it, because you'll still get the air pressure that you need. So it's a nice, simple, easy concept. But of course, some people may have difficulty tolerating that, okay? I tell you, if you have difficulty tolerating that, go see the doctor, because there's a lot of adjustments that can be made. Another thing is you can go see a dentist to get what's called an oral appliance. And what that does, it goes in your mouth, it fits to your teeth, and what that does is moves your bottom jaw forward. By moving your bottom jaw forward, it makes this whole area bigger. By moving the area, making the area bigger, you'll have less sleep apnea. So it's either you're treating yourself with air pressure to keep the airway open, or making the airway bigger by moving your bottom jaw forward. And you might have heard of something called Inspire, which is an implanted device which helps treat your sleep apnea. It's a device that's implanted in your chest, and you run electrodes to your throat, to your muscles in your neck area. And at nighttime when you sleep, you turn it on, and what that does is stimulates your muscles to keep your airway open. That works very well too. But of course, you got to see which one is the best for you. Most people start with CPAP first.
Okay. So how successful is treatment? How soon do patients start to feel a difference?
So if you can tolerate CPAP immediately, people usually notice a difference within a week.
Wow.
Okay, they start feeling more refreshed, less fatigued. About 80 to 90% of people feel the difference within the first week if they're able to use the machine for at least 6 to 8 hours a night.
Wow, that's great. And we talked about some of the benefits, that they feel more refreshed. That's the initial benefit. What other benefits come?
So you sleep better, more energy, and your blood pressure may be better controlled. It can improve your blood sugar a little bit. So your hemoglobin A1C, for diabetes control, it may go from like 7.2 to 6.9. It improves a little bit. And then also, it can help prevent, it's a great preventative stuff as well, to prevent future medical issues.
That makes a lot of sense. But what do you think are some of the barriers that patients present when seeking treatment for sleep apnea?
In some areas, not as many sleep doctors or sleep physicians or people who do treat sleep apnea, or having access to sleep testing. That's the biggest barrier. In other areas where there's still a lot of access, people are worried about the treatments. And they say they don't want to wear a mask, something over their face. No one wants to do that. But even once they start using it, one thing is I liken it to a pair of shoes. You don't know what shoe you like to wear it and walk around in them. So eventually, once you find something that works for you, people do feel better. So it's not as bad as many people think it was going to be.
Yeah, just breaking them in.
Yeah, exactly. You got to break it in.
All right, that's fair. So when it comes to overcoming the barriers, what advice would you give to patients?
So there's a lot of stuff we can do. We can even have, for example, after we do the sleep study, before doing CPAP, or and see a dentist, we can have you try on the mask, see how it is. Have like a test drive, that's per se. So you know what you're dealing with, So, and then also, another thing I say is, trying these things, these are physical things, they're not medications. There's no real medical side effects. So it's not going to harm you in any way. You may not like a mask on your face or something you wear in your mouth, but it's not going to cause any long-term effects on you. So there's no side effects. It can only help, it won't harm you.
Very good. Improve the quality of life, not just for themselves, but I guess anybody else who has to live with them or sleep in the same room with them, right?
Exactly. Your partner will be sleeping better as well as you.
And if you're refreshed, you're better, happier coworker.
Yeah, coworker, father, mother. Yeah, more energy to spend with the kids.
Excellent.
Yeah.
So you've answered all of my questions, but is there anything else that I didn't ask or you'd like to add?
Well, sleep apnea is very common. So definitely, if you have any sleep problems, that's all you got to do is tell your physician. They can order a sleep study. Anyone can order a sleep study, not just a sleep physician. Your primary care doctor can order if they feel comfortable, and then refer you to a sleep physician as well.
Excellent. Thank you so much for your time today, Dr. Condopanini.
My pleasure. Thanks for having me.
Thank you so much, Dr. Condopanini and Leilani. Thank you for being with us here today. Next up on our program, we're going to hear an interview with Dr. Yelena Galumian. Dr. Galumian practices hospital medicine at Englewood Health. She is board certified in internal medicine and has been a member of the Englewood Health medical staff since 2010. Dr. Galumian is originally from Armenia and received her medical degree from the Russian State Medical University in Moscow, Russia. She then went on to complete an internal medicine residency at the North Division of Montefiore Hospital in the Bronx, New York, where she also served as chief resident. Dr. Galumian serves as a clinical assistant professor in the Department of Internal Medicine at Hackensack Meridian School of Medicine. As a hospitalist, she is involved in various committees at Englewood Health. Due to her passion for assuring the best patient experiences, she is serving as part of the Patient Family Advisory Council. Dr. Galumian is a senior fellow of the Society of Hospital Medicine and has served as president of the Northern New Jersey chapter of this society. Dr. Galumian has been a vital team member with the Bloodless Institute since her arrival here over a decade ago and takes care of our bloodless patients who don't have a local physician. She is also instrumental in assisting us in transferring patients who desire to be treated at Englewood Hospital but who are currently inpatients at other medical facilities. We welcome Dr. Galumian. Thank you so much for being here with us today. You have been such an important and integral part of our program for so many years, and we really want to thank you. The audience may not be familiar with a hospitalist and what a hospitalist does. They may not be familiar with the term. Could you explain to us what you do as a hospitalist?
Certainly. First of all, I want to thank you for inviting me for this presentation. I've been working in Englewood Hospital for 12 years already, and I've been working all this time with Department of Bloodless Medicine and Surgery. So who are hospitalists? We are the hospitalist is a movement that was started about 25 years ago, and we are all internal medicine board certified physicians who just make our work to work in hospital, and we don't have any outpatient practice. So we are specialized in taking care of hospitalized patients only.
Mm-hmm. So I'm understanding that you don't have a private, or the hospitalists don't have a private office. Your practice is limited and solely with hospitalized patients, correct?
That's correct. We do have an office within a hospital, and we don't have any outpatient practices. So we only are specialized in taking care of hospitalized patients.
That sounds like that would have a lot of advantages. Can you tell us what some of those advantages are?
So we believe that we're more efficient because being here 24/7 and knowing pretty much everyone in a hospital, whether it's nurses, physical therapists, care coordinators, all the specialists, obviously, we work very closely with them. So it's easier for us to make arrangements and changes in management of the patients multiple times during the day. Some doctors in outpatient practices, they will come around in a hospital and then they will go back to their offices. So it's not probably the best efficient way of managing things, and they won't come until next day. We can attend to the patient multiple times a day and obviously address all the test results and recommendations of the consultants on an ongoing basis.
Well, that's excellent. Many times we hear our patients say, I want to come to Englewood Hospital, but I don't have a primary care physician. Or I want to come, but I live far away, my doctor isn't local. So that would address that, wouldn't it?
Absolutely. We do take care of all the patients who don't have a primary care physician, who are traveling and happen to be in New Jersey, but we also have a large network of physicians right here in the community who partnered with us, and we take care of their hospitalized patients so they can have more time to spend in their offices while we do what we do best.
So if a patient comes to Englewood Hospital and they're not from around here, and they do have their own local primary care physician, but they're your patient while they're here, how do you connect with their doctor in order to let them know what's going on, not only while they're here, but when the patient is discharged, in order to continue or to have that continuity of care for their doctor? How do you interface with their primary care physician?
That's a great question, and it's a big part of what we do. Electronic medical record makes it easier, and for most of the doctors in the community, especially the ones who are affiliated with Englewood Health, they can see all our records every day when they look in a computer. For the ones that are out of state or not affiliated with Englewood, we contact them with any significant events. I'm not going to tell you that we contact them every time and all the time, but what I personally do every time I discharge a patient from Englewood Hospital, I give them my business card and I always tell them, if your primary care doctor wants to hear anything about your hospitalization, please tell them to call me.
Excellent.
And that's how, we try to make it happen.
Beautiful. Very, very much appreciated. So, Dr. Galumian, if a patient is in another hospital and they want to be transferred here because they want the benefits of the bloodless program, can you tell us what should that patient do and what should they not do?
If something is wrong, they should go to the nearest emergency room and get stabilized by the physicians there.
Okay.
And once everything is under control, they should contact Department of Bloodless Medicine and Surgery and be transferred here if it's appropriate. We do have defined protocol between us and Department of Bloodless Medicine and Surgery, and we make it possible and relatively easy when it's appropriate.
Very good. I can tell you that what we don't want to hear is, I have chest pains and I'm driving myself to the hospital. No, we don't want to hear that.
We don't want
If you're
that.
having a heart attack, if you're having a stroke, we do not want to see you here. Go to the closest emergency room, as Dr. Galumian mentioned, get stabilized, and you or a family member or your healthcare agent can give us a call here in the bloodless department and we will facilitate the transfer. Very good. So, Dr. Galumian, you've been here for a dozen years. Can you tell us how you feel, not only as being a physician with Englewood Health, but as a very valued member of the Bloodless Institute?
Thank you so much, Nancy. I live here. I love Englewood Health. I think this is a great institution. Of course, we can do much better, but we're trying our best. And when it comes to Department of Bloodless Medicine and Surgery, and specifically our wonderful Jehovah's Witness patients, I can say that personally, as a physician, I learned a lot medically, and we all are learning on a daily basis. And it's been a great collaboration and work to help this specific, population of patients. It's been wonderful.
Wonderful. So when you came here, you may have had a little bit of a different view of bloodless medicine. How has that changed? Has your viewpoint about treating patients for whom blood is not an option, has that changed over the last dozen years?
Very much so. Very much so, yes. We're much more sensitive to patients' beliefs and needs, and we're also respectful of those, and we're also much more courageous and brave, looking at those low hemoglobin levels and handling it, and we see these people doing very, very well.
Well, we'd like to thank Dr. Galumian for joining us today. Well, next up, we're going to interview Dr. Michael Soroyu. Dr. Soroyu is Medical Director at the Wound Healing Center at Englewood Hospital. He is an assistant professor of clinical surgery and a board-certified wound care specialist. After earning his medical degree in Romania, Dr. Soroyu went on to his internship and residency in general surgery at Cabrini Medical Center in New York. Following this, he completed advanced training in wound care, working as a wound care specialist at several institutions throughout New York City. Dr. Soroyu sees patients with chronic, non-healing wounds. He specializes in the evaluation and management of patients with diabetic, arterial, venous, and pressure injury wounds. He has repeatedly been named to the most prestigious New York area lists of top doctors, including New York Magazine's Best Doctor list, as well as the Guide to America's Top Surgeons list. We welcome Dr. Soroyu. Dr. Soroyu, thank you so much for being here with us today. We appreciate you taking your time. You are the director of the Wound Healing or Wound Care Center. So let me ask you, what types of illnesses or injuries are treated here at Englewood Health at our Wound Care Center?
We treat wounds. That's what the concept of Wound Care Center is. And as well known, comes a time when they said when it's time to treat these wounds or how we classify this type of wounds that we see. So basically any wound or any injury which does not get better in a period of 4 to 6 weeks, depends how the treatment goes, with proper wound care, we have to refer it to us to proceed to a next step, which will be the advanced treatment, which we are providing here. As type, we have every type of wound you can imagine. I mean, we can do post-surgical wounds, pressure ulcers, mostly diabetic foot wounds, venous ulcer wounds, arterial wounds, anything which does not get better, we'll take care of it.
Wonderful. So thank you for that explanation. What would happen to a wound if it was left untreated for a long period of time?
That's not good,
Not
obviously. So a long period of time, it's defined probably, I'm assuming, a couple of days. Now, definitely a wound which is not treated, it's an entry point of infection into the body. We all know that the most important role of the skin is to protect it from any infections which is around us. Once the breach is obtained by a wound, an infection can occur, which can lead to complications, cellulitis, inflammation with lymphedema, and many other problems, which can be easily avoided by our way of treating them.
So if I have a diabetic wound, some kind of open sore that won't heal, is it okay to just treat it at home? I think my first inclination would be to just keep it clean, expose it to the air, and just let it heal itself. What's wrong with that statement?
Every single word.
Okay.
First of all, if you have diabetes, obviously we have a diabetic prevention care here at Englewood, which is done through diabetic people who teach you what to do and how to take care of your feet mostly, because that's what the diabetic ones come. We all know diabetes affects your circulation, so that's another issue that has to be carefully assessed. And at the same time, we have to be careful how we treat. People with diabetes are having a high propensity for infection. So then we have to be careful that is taken care of immediately. Any redness around the wound, it's not good. It's a sign of a possible infection, obviously inflammation. So what the first thing to do is obviously keep it clean and see your primary care physician. If he decides that you may need some further treatment, you will refer to the Advanced Wound Care Center. But as a rule, if the wound doesn't get any better in 7 to 10 days, or have a drainage which is excessive, or have a redness which is not allowed there, has to be immediately referred.
And as far as the other statement, as far as leaving a wound open to the air, which many of us have always been taught, which is probably an old wives' tale, what is your response to that?
Well, we have a couple of no-nos into the wound care, and one of them is do not leave it open to the air. Why? Because as I always tell my patients, said you have to remember, or you may not remember because you're too small. In your mother womb, when the embryos develops, it's not surrounded by air. It's fluid. That skin, it's not used to air. It's used to moisture. So that's very important. Mostly, many people know that in a very dry environment, winter, dry wounds, dry rooms with air heating, the skin gets very dry and cracks. What a crack in the skin is an infection. That's not good. So obviously, we do not advise at all to leave the wound open. Secondly, they say, well, doctor, I want to create a scab, so that's going to keep me. That's true. Scab acts as a natural dressing, but scab also acts as a wall from the skin to grow back and heal the wound. So that's not something we want.
So at the wound care center, a scab would be something that you would remove then,
Absolutely.
because it would not help healing. Oh, that's very
Absolutely.
interesting.
Yeah, unfortunately, sometimes it's a little painful, but we have to remove the scab because number one, stops the healing. Number two, what's underneath? Sometimes you'll be surprised how much infection or maybe some other materials are right underneath that. So yes, we do the cleaning.
Excellent. We have here at Englewood Hospital a number of hyperbaric chambers, and that is something that's used in wound care, and especially for bed sores or other wounds that are having difficulty. What is the whole thought behind using hyperbaric chambers? Maybe you could explain what it is, what it looks like, and then how it's helpful.
First of all, hyperbaric treatment, or HBOT as we call it, it's an advanced treatment of putting the patient in a controlled environment of high pressure. It's going from between 1 and 2 atmospheric pressure inside of the chamber. So it's basically a pressurized chamber. You can think similarly like an airplane, which goes up there and the cabin gets pressurized, except that the pressure level is less. Secondly, the patient is fed inside of the chamber 100% oxygen. Now, obviously, this oxygen is breathed into the patient and dissolved into the blood. We all know that the oxygen is carried out by the red blood cells in a normal atmospheric pressure. In a hyperbaric atmospheric pressure, the oxygen dissolve in the plasma, dissolve into the fluid, so the capacity of carrying goes up from 10 to 20% to 400%. And we all know that without oxygen, there is no life. So oxygen helps healings the wound, epithelializations, removing the infection, removing the swelling and the lymphedema. And overall, the patients feel very, very good after that.
So do you have any suggestions for the prevention of wounds for those who are bedridden? That's something that happens quite frequently. We know bed sores are difficult to treat. Do you have any suggestions for treatment?
Well, there is a saying, and especially in bed sores, we call them pressure ulcers, because pressure is the reason for the ulcers. Mm-hmm. And lately, the terminology actually changed to pressure injury now. But as I said, we have a saying, it's easier to prevent them than to treat them. And prevention is very important. Every hospital and unit has something which is a pressure prevention plan. So then we have to educate basically the family, the patients, the elder patients, how to prevent them. One of them is skincare. Good skincare prevents wound care, obviously. Secondly, it's to have a good nutrition. It's very difficult to prevent a pressure ulcer on a patient which is only skin, and the skin relies on what we call it bony proeminence, which penetrate the skin. Once the skin is on bony proeminence, because of the pressure, there is no oxygenation. And here we go. No oxygen, no healing. So that's another thing that has to be offloaded. Has to be a nice mattress, have to be a proper cushion if they are wheelchair bound, obviously. And the last thing will be to prevent any infection. And those are the guidelines to kind of the important things to look at the pressure ulcer in this type of patients.
Thank you. We touched on this, but maybe you can reiterate, when does a patient know that it's time to stop treating themselves at home and say, I need the wound care center?
Any wound which, as I said, doesn't get better in 7 to 10 days with regular treatment, which means the wound is cleaned, properly covered, properly taken care of. And talking about cleaning, there is a major no-no in wound care. Never, ever use hydrogen peroxide. Never. We use hydrogen peroxide to clean our lab coats from blood, but nothing else for. Now, obviously, there are other indications for it, which are in major surgery or other things, but in a regular wound care, especially cleaning and with hydrogen peroxide is not good. Burns the wound completely. And I keep on telling them, so, you see, put a drop of hydrogen peroxide on your hand, see how it's bubble. That's not good. So, cleaning the wound with normal saline, which is very easily available, covering the wound with proper antibiotic or proper dressing, and see what happens. If it doesn't get better, as I said, in 7 to 10 days, then we have ways to clean and take care of it.
Okay, so we'd like to definitely ask our audience if any of you are dealing with this. And the reason that we have you on our program today was because as a result of our last seminar, you were requested. People wanted to know, what do we do about wound care? It is a hot topic. It is something that's important. It is something that people are dealing with every day, especially if they're caretakers for elderly patients. It's important. So we just like to mention to everyone, if you need Dr. Soroyu, if you need wound care, please don't hesitate. You can call the bloodless office. You can let us know. We can give you Dr. Soroyu's number, and we would be more than happy to be able to assist you in getting the proper care.
It's always available at 3361. We are there. And if there is any questions, I'd rather have them call me and tell them this is important or not than make their own decision.
Beautiful. Thank you, Dr. Soroyu. We appreciate your being here with us today. Well, next up, we are going to interview Dr. Alicia Skirimbas. Dr. Skirimbas is a family medicine physician here in Englewood, New Jersey. She is a fellow of the American Academy of Family Physicians and an associate professor of family medicine at Georgetown Medical School. Dr. Skirimbas is also the medical director of Life Source Hospice and is a certified medical director by the American Medical Directors Association, as well as a certified hospice director. Dr. Skirimbas attended Barnard College, where she was the recipient of the Janeway Prize. She completed a post-baccalaureate at Vassar College and attended the University of Pittsburgh School of Medicine, where she graduated with honors in family medicine. During her residency at Overlook Hospital in Summit, New Jersey, she specialized in geriatrics and hospice care. Dr. Skirimbas is a partner in Englewood Primary Care, which provides comprehensive primary care in numerous settings, including the office, hospital, home, nursing home, and assisted living settings. She is on staff at Englewood Hospital and has been a member of the Bloodless Institute for many years. She also serves as on the Professional Practice Evaluation Committee. Dr. Skirimbas, we look forward to you being interviewed by Leilani Rangel.
Dr. Skirimbas, thank you so much. I'm glad we finally have a chance to talk a little bit. We've been eager to speak with you so you could tell us a little bit more about mental health and how we can take better care of it within our community.
Oh, thanks for having me, Leilani. I'm a family doctor, and mental health is a common issue I see in my patients. It comes up usually because I'm investigating what are their barriers to taking better care of themselves. And in many cases, when I really talk to a person, I discover that the reason they can't do all of those things that result in good health is because they're depressed or they're anxious and they can't get motivated. They don't want to leave the house. And it's certainly a lot of these things have worsened since COVID because people are very isolated. They may have been through COVID or had, the trauma of a sick family member or a family member who died. So I've seen an exacerbation of depression and anxiety in my patient population.
Wow, I can only imagine. And when you see these symptoms, many people associate depression with feelings of overwhelming sadness. But are there other symptoms that can be mistaken for depression but may actually have some kind of underlying medical condition?
There definitely are medical conditions that can mimic depression. In the elderly, the onset of dementia often looks like depression, or they coexist. Sometimes a patient will say they just don't feel like doing anything. I have no energy. I have no get up and go. And the reason may be that they're severely anemic, and that takes a blood test. You can also have a disorder in thyroid. A common problem is a disorder in like a B12 vitamin. So typically I'll investigate those things with a blood test first.
Yeah, to rule those out before looking into another avenue. Okay. So as you mentioned with COVID and the extreme conditions that we've all experienced in the last 2 years, how do you help patients manage those uncomfortable and sad feelings that they may be presenting to you with?
That's a good question, because there's different types of depression that exist out there. There is grief, which is a normal human response, and we don't have a cure for grief. There is time and support and following somebody over time to make sure that they're getting through it. Depression is more of a health disorder, and it really takes some time, and you have to talk with a patient in such a way that they feel comfortable to admit to you what's going on. You can't do it in a 5-minute visit. You often can't do it on a questionnaire. Do you have depression? No. But if you ask, and you have to ask things about like, well, how often do you enjoy, out of a week, do you enjoy most days of the week? Or are there things that you like doing? And they'll be like, no, I used to, go golfing and I really don't feel like doing, you have to really ask. And if you come up with someone who feels sad or depressed most days, and they don't have an obvious trigger for it, they just have this feeling. They can have a perfectly good life and be depressed. Depression is, it's a brain illness that is not always in reaction to something. Certainly made worsened by crises such as, well, certainly isolation from the pandemic, but also common life experiences like loss of a job, loss of a spouse, divorce, losing your home, just moving to a new home and all the adjustment. Those can all be triggers for depression or anxiety.
Sure, sure.
Yeah.
And like you mentioned, there's a lot of stigma, not just within oneself, but even to admit that there might be a problem. And so, like you said, creating that safe space for the patient to be able to talk about those things without feeling embarrassed.
Absolutely. I usually spend a little time trying to destigmatize it by talking about it more as a neurotransmitter deficiency. Mm-hmm. You're low in serotonin, and there are very safe medications that will gradually improve your serotonin levels so you feel normal again. And we've had for at least 2 decades now a very safe class of medications that improve serotonin levels that can be commonly prescribed by the family doctor. And that's important for primary care providers to really have a good handle on, because the wait for a psychiatrist can be 6 weeks. I am very happy that the advent of Zoom visits with therapists and psychologists has now opened up a lot of room, because you can get a Zoom visit with someone in Colorado. And so that has helped a lot with getting therapy. But, the visit for a psychiatrist may be a long wait. And there's a lot you can do for a patient as a primary care provider for, ordinary non-psychotic problems like depression or anxiety before they get a chance to see a specialist.
Very good.
Yeah.
Can you tell us about some of the other resources that you can also point them to, especially if they're if they sense that there might be a crisis looming?
I'm very particular to always remind everybody involved that if you look at suicide rates, you must think of depression as a potentially fatal illness, like cancer. Somebody who's seriously depressed must be treated as aggressively as you would treat something else life-threatening. So if there's any signs that the patient might be that seriously depressed, they should themselves call 911 or suicide prevention hotlines. Those are well staffed nowadays, and you can get somebody very, very willing to sit and listen to you as long as you need to talk. And that often is an intervention, a life-saving intervention all by itself. But if there's any concern, we do hospitalize people to put them in a safe place while a psychiatrist can get them on a regimen that gets them out of the danger zone.
So I think one of the things that you mentioned was that people often feel, I have a good life, I have somewhere to live, I have a steady job, my family's wonderful, I shouldn't be depressed. I shouldn't feel this way. And so they judge themselves harshly, and that can bring a measure of stigma. So they feel like it's wrong for them to complain. Is that the case?
Exactly the case, because a person who has nothing to complain about doesn't want to tell me that they feel depressed. because they know they have nothing to complain about, right? So that is often, it's very interesting because in the office visit, I come in and how is everything? Everything's great. And then in the course of the visit, as we're talking, if I, a lot of this is sometimes body language, eye contact, asking them about their interests, and you sense a lack of lust for life. I mean, just sort of this really oppressive sense that they're not enjoying life, that it's a burden. And it's usually at the end of the visit that I can go there if somebody doesn't want to come out and say that they feel depressed. And the stigma is attached to depression because because in the old days before we had good treatments for it, you might end up locked away if it was bad enough. Or also it seemed people feel like they shouldn't complain because there's nothing wrong. They don't have a physical ache or it's not an organ they can point to. But it is a barrier to good self-care often. And if I can talk to a patient about it as really just another medical problem that we have good treatment for, it's very, very treatable. And it's so common. It might be as many as 1 in 4 or 1 in 5 adults have suffered from a depression episode in their life. And so I wish it got the same attention as hypertension, but it is just as treatable. And not always, medication is a second line treatment, depending on the severity. A lot of patients, if you bring it out in the open, they have some time with a therapist to talk about it. And they do some modest interventions, like if they're able to, if they're not severe, go for a walk outside every day for 20 minutes. So the combination of that little bit of exercise plus a therapist has been found to be as effective as low-dose medication. So if a patient doesn't want to take a medication, there's a non-medical, non-pharmaceutical place to start. But then if that's not effective, I usually ask them to really give medication a try, because on the right medication, a patient does not feel altered. They are not tranquilized or sedated. They just gradually over time feel normal again, which is the goal, right? So we do have a lot of options in primary care to treat depression. Most often, with a lot of people, the problem is getting them to admit it. If they come in the door and the first thing out of their mouth is, "I'm depressed," you're dealing with somebody who's usually in pretty bad shape. Okay, they're not mild at all,
To cry for help.
And that might be the time when I get a psychiatrist on the phone just to get an opinion on where to start with this, because it's pretty bad. But the stigma is unfortunate. The stigma is even more severe if you are a healthcare provider, because healthcare providers are expected to always be perfect, never suffer from any of the things we treat the rest of the human race for. And there are other professions in the United States where the professional code is that you must visibly never have anything wrong with you, and you go to work sick, and it's sort of a job lifestyle we follow in the U.S., and it does sometimes prevent people in the healthcare professions from seeking help for certainly all the trauma we've all undergone with COVID. It was just, it was really hard on all of us who were there, at least in the beginning of COVID. But leadership, I've heard in some of our group meetings where our chief will give a talk and emphasize the fact that I want all of you to take care of yourself and get help if you're feeling depressed. So that often, in the healthcare profession, that can come from above. If you have your chief of medicine or your chief of nursing, put it out there, make it available, remove the stigma by talking about it. Very important.
Yeah. And part of removing that stigma is when you talk about it to have someone say, "Me too,"
Yes,
right?
that is so important. Yes,
That they're not alone. This
that
is
is
more common than they.
yes. Well, I do like to tell people that they're not an outlier if they have depression. I like to tell them just how common it is, and that for a lot of people it's self-limiting. So many people will just have 1 or 2 bad episodes in adulthood. People who've had depressive episodes since their teens have it really as a diagnosis that I put on the chart, because it may be controllable like high blood pressure, but it's never going to disappear from their life, and it's manageable. And then there's the other subset who've had a crisis or trauma or suffered from isolation, and they may be self-limiting. They may need 6 months to a year of treatment and then really go back to normal.
Yeah, and the tremendous compassion that doctors and patients feel when a patient is diagnosed with cancer or heart disease. Everybody rallies around the patient.
You are so right.
And yet when they're diagnosed with depression or anxiety,
you are so right.
There's not that sense of, we're behind you. There's like, ooh, you're what? You're sick? But we're all human.
I try to counteract that with the patient is to say, how awful for you to be suffering from this. How awful to wake up every day feeling like this. This is really terrible for you. And you shouldn't suffer with this, because as you said, the cancer patient gets a lot of sympathy and empathy. And the person who wakes up every day feeling like life is hopeless, that's a really bad place to be. And you need to sympathize with it.
They need just as much compassion and empathy.
Yeah.
And we're so grateful that as a provider, you give that to our patients. And that you hope you receive it as well.
Thank you very much. Thank you.
Thank you.
Thank you so much, Dr. Skirimbis, and thank you, Leilani. We really appreciate that. Well, next up we have a special treat. We are going to hear from one of our patients, who is Clark Gabrielson, with his physicians, Dr. Adam Arnofsky, who is Chief of Cardiothoracic Surgery, as well as our esteemed cardiologist, Dr. Dennis Katechis. And they are going to be in an interview with Sherry Ozawa, our bloodless consultant, talking about Clark's recent open heart surgery.
So it's a real pleasure and one of the best parts of our meetings to have with us patients who can tell us a little bit about their experience with the Bloodless Institute at Englewood Health. And Clark, you've been around Englewood Health, Englewood Hospital for many years. You and your family, we've known each other for decades at this point. And you always think it's not going to be you as the patient, but recently you had some experiences, right, as a patient here at Englewood Hospital and our Bloodless Institute. So why don't you tell us a little bit about how things transpired for you?
Sure. I guess the earliest sensations I had that there were problems were during, I guess, late 2018 into 2019. I just got a greater sense of breathlessness when I would be walking up inclines or long flights of stairs, and I just initially just chalked it up to being out of shape. But during a kind of routine physical at my primary care physician, he had the stethoscope on my chest, and he heard something that I guess alarmed him, or at least brought up a cautionary note. So he said, look, I'm hearing something. I don't know if it's a problem or not. It could be a murmur. I'm not sure, but you should get more testing done. And that's when he sent me, and I got my first of what would be many echocardiograms. And it was from that he found out, he says, you've got to see a cardiologist. You have, but that's the first time I heard the term stenosis with reference to my aortic valve. So he said he had some recommendations he could make, but I told him I preferred to go to Englewood. I wanted care that I knew was going to respect my religious beliefs, and I didn't know where it was going to all end up. But this way, I thought it would be best that we started right with a group of doctors that understood and gave bloodless surgery its due.
So, Dr. Kateches, Dennis, if you could kind of step in here where Clark met you and tell us a little bit about his condition and how you approach that as a cardiologist.
I listened to his story, and the physical exam was telling. I knew that we would be dealing with something that would probably require more than medications to take care of. An echocardiogram confirmed the diagnosis of a narrow aortic valve. The aortic valve is the main valve that opens and closes as the heart pumps, and it allows blood to flow through the main artery called the aorta to the rest of the body, and it closes for the purpose of preventing that blood from returning back into the heart muscle when the heart muscle relaxes. The important thing in his case, in Mr. Gabrielson's case, is the fact that it was easy to detect the fact that he probably had the pathology that he was born with. He had an abnormally structured valve, probably from birth, and he became narrow at some point in his life to cause symptoms. And the echocardiogram that I did detected an aneurysm that was not that large. It was smaller than many of the patients that I see and that Dr. Arnowski takes care of surgically, but large enough to make us sit down and have a discussion about what the appropriate treatment should be.
And then the same question, or Adam, you too, can you just again explain to the audience, we hear the word aneurysm all the time, right? It's a scary word. Just a sort of a simple explanation of what that is.
So an aneurysm is basically defined as an abnormal dilation of any blood vessel in the body. So the way I usually talk to my patients, and Clark, these are probably the exact words I use when you're in the office, any of these arteries, the aorta in particular, is like a garden hose in the backyard. And if that garden hose gets worn out over time, it can dilate. And as it dilates, the wall of the vessel or the wall of the garden hose gets thin. And as it thins out, bad things can happen to it. And that's why we talk about replacing and repairing those aneurysms to prevent those bad things from happening.
And we also have, this factor why we're here talking today, blood transfusion is not an option for Clark. And we're very comfortable with that at Englewood. Why is that sometimes challenging to other places? How do we get ready as a team so that we are much more comfortable? And tell us a little bit about what this looks like from a surgical perspective.
Heart surgery around the country is typically challenged by the necessity to transfuse patients. Upwards of 50 to 80% of patients in some places are getting blood transfusions. So it's very, very common. So what I do when I talk to my bloodless patients is, we kind of come up with an agreement. I will, do the surgery without blood, but we have to work together in the pre-op optimization. And really getting the bloodless program, it's really preoperative, intraoperative, and postoperative as well. So it's taking care of the patient throughout the process. So preoperatively, we boosted Clark up as much as we can. We got his blood counts as high as we possibly can so that we have that safety net to do the procedure. That's the preoperative stuff. Intraoperative, we have a couple of tricks that we do. First of all, meticulous surgical care. We can't be sloppy at all. We can't lose any unnecessary blood during the procedure. That's first and foremost. But there's a few things we do, other things we do intraoperatively to kind of mitigate and reduce the need for transfusion. An operation like the one Clark had, we have to use a machine to circulate the blood as we temporarily stop the heart and do our work. In Clark's case, we did two things. We had to replace his aortic valve, and we had to replace a segment of his aorta, that main blood vessel, because it had dilated. And then post-operative, of course, monitoring the patient closely, limiting blood draws. If there's any signs of bleeding, we have to jump on that very aggressively so that it gets stopped, and we don't allow our patients to become severely anemic. So Clark was a challenge, but he had a nice, happy ending, as you can see by the discussion here today. So,
the surgery was done on a Tuesday. I came home that Sunday, 5 days later.
Yeah.
So somebody did something right. There's great wisdom involved, both, I think, from an earthly source and maybe a little higher as well.
Sure. And if you'd like to make any comments, Adam, sort of about, or Dennis, about the way this has impacted your care of all patients, right? You spoke eloquently about how we specifically take care of our patients for whom blood is not an option. For other patients, blood may be an option in terms of their wishes, but what have we learned that has made us better providers?
From at least what's been published, and it has been, again, published in a very convincing fashion, I feel comfortable and I have endorsed and accepted the fact that blood transfusions are potentially harmful, and therefore we should avoid it in as many patients as we can. So through the initiatives of the bloodless program, I think we've learned and we've been able to expand that approach in care to our population, patient population in general.
Yeah, absolutely, Dennis. I agree with you. You know, heart surgery is probably one of the biggest utilizers of blood transfusions, probably in the country, the world. And the tips and tricks and outcomes that we've experienced without using blood really is something that we're now applying to to all comers. And if we can optimize patients preoperatively, if we can do our meticulous operations and use our intraoperative tricks, that just helps us get the outcomes that we've been able to be proud of over the past years here at Englewood.
And from a patient's perspective, I can just say that knowing that my personal beliefs were not only going to be tolerated but respected, I think helped me heal faster. I think it's just good for the body to feel less stress, feel that the people caring for you really do care for you.
And I'd like to speak to just something in that a little bit, right? Many times patients feel like they're sort of in the middle, right? They hear something from one physician who says, we need somebody else on the team, and they might feel lost. How does our cardiology team work closely in terms of teamwork and communication with our cardiac surgery department? Because you all do such a wonderful job in making sure patients don't get lost or feel lost.
We have a very close-knit group at Englewood. We are constantly on the phone with each other. We have multidisciplinary conferences once a week with the full division, once a week with just kind of the structural heart valve division. So we're constantly bouncing cases off of each other. Plus, we're all very collegial and close and pick up the phone without hesitation to call or text about patients that we're seeing that we want to discuss together to come up with a comprehensive plan. So I think that's one of the unique things about our group, both cardiac surgeons and cardiologists, that really allows us to provide great care for our patients.
And if I can add too, this is why I'm so glad I made the decision early on to start with, say, Dr. Katechis, because later on, of course, Dr. Arnofsky became involved with the CLL, Dr. Janoski, the oncologist, and just knowing they're all under one roof and had access to each other freely, I just felt it was more of a team effort than doctors from all over the place trying to get in touch with each other.
So Clark, I'll let you have the last word. There's people that are watching today from not just Englewood or Teaneck or locally. They might, we know there's folks from around the country, maybe even outside the country. Well, what would you say to people who maybe are not in the exact geographical area of Englewood?
Well, as both of these fine doctors have said, the ability to do what they do without blood, it has become and is growing as the gold standard of care. And so I don't think people should feel afraid to look into that, even if they're not of the same religious faith that I am. The ability to look into bloodless surgery as just a healthier way to do medicine should never be overlooked. I think it's many more hospitals now are getting on board, and hopefully that'll continue to grow. I think everyone will be healthier for it.
No, that's great. Thank you. So again, for our audience, right, in the middle of a medical emergency, we want you to call 911 or go to your closest ER. But there are many situations where there is some time, right, to have people like Dr. Katechis and Dr. Arnofsky and the rest of the medical team analyze your case, take a look, and see if you can be helped, even if you're not geographically directly in the area. So, on behalf of this whole audience of listeners and watchers, Dr. Katechis, Dr. Arnofsky, as representing the larger clinical staff at Englewood, thank you so much. for the years of dedication that you have to this program, to this institution, to this patient population. You've touched so many lives. And with these events like this, so many more know about the work that we've done, and you make us feel proud and grateful. And Clark, we are so happy that you are looking well and feeling well, and that your family's doing well, and that you're with us. We hope you come back just as a visitor, but we know if you need more, there's great folks like these gentlemen and others to take care of you. So again, thank you all so much for telling us the story, and we're happy you were here today.
Thank you. Thanks, Sherry. Clark, good to see you.
You too. Thank you, guys.
Thank you.
We hope that you have enjoyed today's program. We would like to thank the participating physicians, Michael Soroyu, Skrikan Kandapanini, Yelena Galumian, Jay Reidler, Alicia Scarimbas. In addition, we would also like to thank our patient, Clark Gabrielson, as well as his physicians, Dennis Katechas and Adam Arnosky, for taking time to be with us today. Before you leave, you have the opportunity to leave comments and questions for our coordinators. You can also feel free to let us know what other topics you would like us to discuss in our programs. Remember, friends, we're available 24 hours a day, 7 days a week for emergencies. We are the Bloodless Institute at Englewood Health.